I'll start off now, and if you can't see my slides moving, please let me know. So, unlike in the other disciplines of medicine, in psychiatry, the emergencies actually differ. Psychiatrists are a lot worried about risk to a person's own life and risk from the person to another person's life. And most of the time, what we consider as emergencies arise from these two factors. Either the patient is risky to himself or the patient is risky to someone else. So in this lecture, we will identify some situations which are emergencies specific to psychiatry, because the other medical emergencies you would actually be learning about in other disciplines. Then let's identify and learn about other risk factors which increase this risk of emergencies in patients, and discuss the principles of management and outline what is the specific management in each case. Okay. Sorry. So what do we consider as emergencies in psychiatry? If you consider about risk to self, then it's about people who might have suicidal ideation, who have imminent, risk of harming themselves. Some people who have come after attempting suicide. Then, of course, there might be certain persons who are presenting with severe self-neglect. It's not only physical neglect, but neglect to take their medications, maybe sometimes diabetic medications, their insulin, which poses a very high medical risk to the person, not taking enough fluids or food, so that compromises the patient, for example, in severe depression. And sometimes even, overactivity, such as in mania, can present with a person being very manic and being very exhausted. Risk to another person from the patient often occurs from being a very agitated or aggressive presentation, which might occur very often in mania or sometimes even in a psychotic patient. Then, in addition to these two risks, there are significant medical risks in related to the medications that we prescribe. So, neuroleptic malignant syndrome arises from the fact that there is increased dopaminergic blockade caused by antipsychotics. Lithium toxicity, because lithium is a drug with very narrow therapeutic index. Serotonin syndrome in especially elderly patients, or where serotonergic medications have been escalated, the doses have been increased very rapidly, or else if there are two serotonergic medications prescribed together. So these, of course, I guess you would have learned in your pharmacology lectures. Therefore, I would not be describing them in detail, but at the very end, let's have a look at how you can differentiate NMS from serotonin syndrome. Okay. Let's first consider the agitated or aggressive patient, because again, a suicidal patient would definitely be discussed in the lecture on suicide and self-harm. Patients with significant self-neglect or refusing fluids or food would be managed as in a severe depressive disorder and very likely to receive electroconvulsive therapy if it poses a very high risk to themselves. So I think those two are also covered there. So that leaves us with the management of the agitated or very aggressive patient. Now, aggression in a person often is not due to mental illness. Now, that is something that we really need to understand. Very often, these are unhappy people, people who are distressed, people who have been waiting for a long while in the queue. Now you saw how people were having fights in diesel queues, isn't it? So they are so distressed. They have to, stay in queues for hours and hours. And when somebody else cuts the line, they feel really angry, isn't it? And it's not because they suffer from a mental illness. It's because they are very distressed and angry because of what is happening around them. So much so that in emergency departments all over the world, management of an aggressive patient is very important, because it's in emergency departments, accident services, and what we call preliminary care units. When you start working in peripheries, especially in base hospitals and district hospitals, they have screening units called preliminary care units. So I as a post intern, I worked in a PCU in Homagama Base Hospital. And there are, of course, patients who come to the OPD. If the OPD doctor feels needs a little bit more care rather than prescribing some medications and sending home, they would be sent to the PCU. And there, you can, all the accidents come there, and all, assaults, and, people who are intoxicated. Then, of course, people who probably might need just a UFR or a blood count and some exclusion, and they can be sent home. So it's a very busy place. Busy places are very prone to be attended by people who are distressed, angry, and therefore they can become violent. Also in prisons, even though there is an overrepresentation of people with antisocial personality traits or personality disorders or with mental illnesses, please remember that crime is very often caused by people who are not mentally ill. Here, of course, now we are talking about managing an agitated or an aggressive patient who is mentally ill. The causes very often differ, but the most important question that you need to identify is this due to that same illness? If it is not due to an illness, then it's a different way of handling it. If it is due to illness, then is it due to derangement of some metabolic cause, what we call organic in psychiatry, or is it only due to a psychiatric cause? How do you differentiate this? Number one thing in managing aggression and violence is identifying when a person is becoming aggressive. Don't wait till the person comes to this level. You need to identify that somebody is going to be now, going to be angry, going to, talk loud, or, going to be verbally aggressive. Before this level of, threatening behavior occurs. So how do you identify these people? So after that, we will discuss how to differentiate organic and psychiatric causes. In the appearance, they would be very likely disinhibited or disorganized. The clothes might be in disarray. The motor restlessness is there. They would be walking about. They would be agitated. They would be gesturing more. And sometimes they are very sensitive to stimulus. So they're startled by noises very easily. Speech is loud. They talk loud. They talk fast. And sometimes if the person is psychotic, they might actually talk. You will find that the speech is not relevant, irrelevant, repetitive speech. The person is saying the same thing again and again. The mood might be angry, irritable, or elated. An elated person can also very often become angry. When you have, I think, probably read about mood, you might have read that a person who is manic can have lability of mood. Lability කියලා කියන්නේ, the mood actually, the speed with which the mood changes is increased. So we say that the mood changes very quickly. So this moment the patient is laughing and shouting, and then the next moment the patient might actually be saying something sad and crying. So that's lability of mood. So if in a manic patient, If there is elated mode, then because the mood is labile, then again they can become irritable very soon. Or else the patient might be psychotic or, maybe even depressed and irritable. In thoughts, of course, you need to look for any persecutory ideation, suspiciousness. If the person, maybe when we were discussing about schizophrenia, I think you might remember we discussed about passivity phenomena. Passivity phenomena are where the person believes that their thoughts, emotions, or physical actions are being influenced or controlled by an outside person or a group of people or a force or institution, something. So when, you can imagine how distressing this might be to the person, because our emotions are ours, our thoughts are ours, our actions are under our control. So if you believe that somebody else is controlling them, your uh, your uh, your uh, what do you say, your identification as an individual is taken away from you, isn't it? So your ego is affected. So therefore, this is a very distressing phenomenon, and people are very likely to become aggressive when they have passivity phenomena, especially towards people that they identify as their persecutors. So if a person actually identifies a person by name as being the persecutor, rather than a person who says the CID is actually controlling my thoughts. The CID is an institution. So you don't know who is affiliated with the CID or not. Or you say that the CIA or the NASA is controlling my thoughts, something like that. You know that the risk is less because it's an institution. The institution is not usually accessible to this person. Therefore, the risk of this person harming those people are less. Whereas if the person says, it's my neighbor who is controlling me and I see him every day, he lives next door to me, I can go and visit him, then of course you know that the risk is high, isn't it? Grandiose delusions are also associated with violence. Very often, what happens is the person expresses the wish to have, to carry out some grandiose plan, or else the person believes that they have some special powers, so they want to heal people. And often, the family is now trying to, stop the person from carrying out these actions. Therefore, the person believes that the family is jealous, or that they are hampering his his progress in life, and therefore they can become actually aggressive. If the person actually expresses homicidal ideation, be careful. You need to take these things seriously. So if the person identifies a person as being a persecutor and expresses wish to harm that person, and then you need to ask, do you have any access to that person? Do you see that person? Do you know where the person lives? Have you ever thought of what you might do to the person? Have you done anything like, bought a knife, or, kept a pole or something, so that, when the person is nearby, you can protect yourself or maybe hit the person? So these are important questions that you should ask from a psychotic patient. In perception, of course, sometimes what we call command hallucinations occur. They are second person auditory hallucinations where a person is told to do certain things. So maybe somebody who the person believes is hears talking to him can actually give commands. The commands can be to harm himself or to harm someone else. So command hallucinations are often able to be resisted by psychotic people, but then of course when they become severely ill, they might find that they are not able to resist these commands, so they might actually carry out these actions. Cognitive functions. In delirium, you will learn that the patient is disoriented and they have poor attention and concentration, and that they are confused and distractible. In these sort of instances, the patient might actually misinterpret certain stimuli. For example, the nurse is coming towards them with the injection in hand to give an IM injection. The patient might actually misinterpret that as the person is coming to stab him. So the patient might become very fearful and might try to, safeguard himself. And be aggressive towards the nurse. Sometimes, people, if the person is delirious, there might be people just having their own conversations, and the person fears that they are actually plotting to harm him. So therefore, he might actually become aggressive towards these people. Okay. So you can understand how different illnesses can present with risk of aggression. So mania, how they can present with aggression, schizophrenia, and of course, even in delirium, how they can actually present with aggressive behavior. Okay, so how do we differentiate an organic cause from a psychotic cause, from mental illness? You have to look for features indicating a psychiatric illness, such as elated mood, irritability, psychotic symptoms. Are there any features suggestive of substance intoxication or withdrawal? The main thing that you use to differentiate an organic cause from a psychiatric, from a very sole psychiatric cause is orientation and attention and concentration. So if a person is very well oriented, then you know that it is unlikely to be due to an organic cause where there is a delirium or a substance intoxication, or there is epilepsy or head trauma. There is always some what we call clouding of consciousness, where the patient appears to be subtly, disoriented, appears to be very mildly even distractible, misinterprets things, maybe running a fever, there is a history of seizures, there's a history of head injury, then always please suspect an organic cause. So it might be head injury, it might be substance withdrawal, it might be delirium due to a metabolic derangement, it might be a person who is having dementia and on top of that the patient has become delirious, it might be an unconvulsive status where the patient is having seizures, but the seizures are not overtly seen as motor seizures, but are seen as behavioral changes. But of course, definitely you would be able to identify some clouding of consciousness. And of course, head injury is famously, famous to be presenting with irritability and aggression with an undetected head underlying extradural or a subdural hemorrhage. So they present with behavioral changes. Okay. So these are the conditions where aggression or violence can occur. So how do you assess the person? You assessed if there is a possibility of an organic cause. You assessed if there is only a psychiatric cause, or in such as in dementia or in substance intoxication and withdrawal, there may be elements of both. For example, a dementia patient might actually become aggressive when a delirium sets in. A patient with psychosis might actually be intoxicated with substances and therefore might present with disinhibited behavior and would actually misinterpret certain stimuli. Assess the risk to self and the others. What is the level of aggression to the aggression expressed in the patient? Is it severe aggression or is it just mild? You can actually talk to the patient and de-escalate it, or you need immediate action to be taken. So, for example, if the patient is actually being verbally aggressive, then there is a risk that the patient might be physically aggressive also. So intervention is needed very quickly. If the person is expressing homicidal ideas towards the other person, then of course you know that the person is going to be very risky. So look for signs which indicate that you need immediate intervention. And then of course you need to have a plan of action. How are you going to manage the aggression? That of course we will be discussing next. So in the assessment, you take history, you exclude any possibility of organic or psychiatric illness, you take collateral from any accompanying person, you speak to family members, if there is a policeman or if there is another doctor who knows the patient, you take the details and identify if there is a possibility of any organic cause or is it just a mental illness. Speak to the medical team. Is there any past history of psychiatric illness that you know of, even though you don't know this time whether the patient is ill? Maybe the patient might be carrying cards, or patient might actually tell you that they had actually been taking treatment. Is there a family history of psychiatric illness, so that you know this might be the first presentation, but you can guess if there is a family history that there is a high risk of the patient developing a psychiatric illness now? Do a mental state examination, a very brief one. You don't need to sit down and do it with the patient. From what the patient is talking to you or expressing and the behavior, you can identify what are the risks. And if there is any suspicion that the patient might be having a head injury or is delirious, you need to do a physical examination as it permits. So you might not be able to go near the patient, go near the patient and do a formal physical examination. But if the patient is up and about and is running around, you know that the patient's blood pressure is okay, right? And that the patient is basically physically stable, so that you can probably, tranquilize the patient quickly. Whereas a patient who is shouting and verbally aggressive but is lying on the bed and appears to be immobile is managed in a different way. Okay, so again, what indicates an organic cause? If the onset is acute, usually a patient with psychiatric illness will give a fairly long history, maybe few weeks, maybe at least a few days, sometimes even months or years of illness. Whereas somebody suffering from a non-convulsive status or maybe head injury might actually have a very acute onset. So the patient was absolutely well a few days or few hours ago, and the family would say actually he became ill very quickly. Level of consciousness, is the most important indicator with disorientation in time and place. So there would be some clouding of consciousness, and if you ask the family or the nurses, they will say that the level of consciousness is fluctuating. Fluctuating, they will say, look, towards the end of the day, towards the evening, the patient becomes more disoriented. They become more confused. They don't appear, they make mistakes in identifying people and things. So that indicates that the level of consciousness is fluctuating. Disorientation in time and place is very important. Out of these two, it is disorientation in time, which is the most important. When we check for orientation, we know plus or minus 1 hour in time is the most important indicator, which, so plus or minus 1 hour is usually correct. So if the time now, the time is 1:39. So if the person says it's 2:39 or somewhere around 2:30 or somewhere around 12:30, then we can still say the person is oriented. But if the person says it's 4 o'clock in the evening, then you know that the patient is not oriented. Place, disorientation in place occurs a little bit later, and of course disorientation in person occurs in very, very late dementia. So that's not very useful to identify any acute causes like delirium. Patient might have short-term memory impairment. The bystanders or other people might say that the person has actually forgotten what happened yesterday. So then you know that there is some organic cause going on. Look for any physical signs indicating a medical illness, such as any fever, any dehydration, neurological signs, or injuries. And usually there is no past history of psychiatric illness, even though please remember that a combination of causes can still be possible. These are the organic causes which cause delirium and maybe the risk of irritability and violence. So hypoglycemia, a patient can actually be hypoglycemic and present as being irritable. Hypothyroidism, electrolyte imbalances causing delirium, and as we discussed, seizures and head injury, and substance intoxication and withdrawal both, and cerebral hypoxia. So in these sort of causes, you need to exclude if you suspect an organic cause. Okay. What are the predictors of violence in mental illness? So we have discussed about organic causes now. Now we are more into psychiatric illnesses. There are certain factors which increase risk of violence in a patient suffering from mental illness. Being male and a young person are very important factors. But if you look at the importance, I think the most important factor is a past history of violence. So, if somebody has been, aggressive in a previous episode of illness, it's very likely that the person will become aggressive in this episode too. So, a past history of violence, for example, in people with personality disorders, if there is a past history, you know that the person is at high risk of violence even later, even with supervision. The next factor I would think is likely to be substance abuse. So, if a person is abusing substances, then it is very likely the person has a high risk of violence. Then, of course, the other things come into place, like, being male or young, or if there are any active psychotic symptoms, or if there are antisocial or impulsive personality traits. So, if you read personality disorders, there is something called cluster B personality disorder. So cluster B එකට තමයි A B C කියලා තුනකට බෙදනවා. A is more like schizoid, schizotypal, paranoid personality disorders. B is more impulsive, narcissistic, borderline, antisocial, histrionic, etc. And C is anxious, avoidant, anarchistic, dependent, those personality traits. So cluster B personality traits are more likely to predict violence than any other personality disorders. How do you manage a potentially violent patient? You have to identify the risk. First thing is you do the assessment, identify the risk. If there is a psychiatric condition, then of course you have to treat it effectively and prevent escalation of irritability. You negotiate with the person, put the person in a place where the person is unlikely to get stimulated and get into fights. Have a good plan, and both behavioral strategies and medicines have to be used in managing a patient. So you need to decide what is the setting. So if somebody is becoming irritable or violent, it is very likely the patient would actually need an inpatient care. If the patient is, we are talking about patients who are mentally ill. And very often you will realize patient. Of course, in Sri Lanka, only patients who are under the Mental Health Act can only be treated in the National Institute of Mental Health in Angoda. But still, you can actually sedate a patient and transfer the patient for involuntary care later. Behavioral management comes first before you offer any medication. It's very important that you try to de-escalate the patient. What we mean by de-escalating is, it's a word that we use in managing aggression in psychiatry. You bring down the aggression level, bring down the activity level. That is called de-escalation. So you communicate in a very calm and clear manner in simple sentences in a language that the person can understand. Repeat instructions again and again. If there is a problem, you address the problem. So if there is somebody shouting, saying that that somebody else has jumped the queue, you say, I'm very sorry, I did not see that. I will see you next. Please wait. I will make sure that the other person goes in the correct turn. Don't make false promises. This, of course, always breaks the rapport between you and the patient. So if you say, very often patients say, I want to go home. And you say, okay, me petta bonna etukata gedara yanna puluwa. But after taking the tablet also, and then the patient becomes angry with you, you said that, if I take the tablet, I can go home. Now you are saying, I can't go home. I'm not going to take any more tablets. So try to reword the negotiation in a way that it is acceptable and you are not lying. For example, you can say, look, we can see how I can help you to go home. And first of all, you need to calm down. And for that, you need to take these medicines. You take this and then we will see if I can help you to make a plan to go home sooner. Make sure that you actually speak with the person in a quiet place, because otherwise what happens is, in a very busy place where people are going in and out, if you start to negotiate with a person who is aggressive, then other people also get into the picture. This is definitely like the petrol queue, where if one person raises his voice, then the others who also feel disgruntled will join in the discussion, and things actually will get worse. So number one thing is, you remember, you actually manage behaviorally. Try to settle the issue, try to speak very calmly, try to negotiate a plan with the person, make sure that the person's issue is addressed in a quiet place, and make sure that you have enough support from your other teammates. So don't go alone into a situation where a patient might be irritable or aggressive. Before you enter the situation, alert your teammates, like maybe your nurses or other staff who can help you out if the situation becomes rather risky. In case that you cannot negotiate a plan, then the next stage is to restrain the patient. Restraint is of three different types. You can actually try geographical restraint, physical restraint, or chemical restraint. Geographical restraint can you actually place the patient in a place where the patient cannot harm anybody else or harm himself, and the stimulation is less. Physical restraint is where you actually physically bind or tie the patient, physically hold down the patient so that the patient cannot harm anyone else. Chemical restraint is you sedate the patient so that the patient is not at risk to anyone else. So patients who are seclusion rooms they are isolated in these rooms when patients become aggressive or violent. So, but in NIMH, the rooms are actually like small prisons. These, the seclusion room cannot be like a small prison. So it's very difficult to, do a really good seclusion room in Sri Lanka. But if you look at it, have a look. Now, these walls, they are actually not made from cement or concrete. They are made from board. So that if the patient gets angry and hits the wall, it just goes through. It will break through. Later, they will always repair it. The room should have water. You can see there's some water, some things inside here. It will usually have some bathroom facilities. And, there is usually a bed with enough, sheets for the person to be comfortable. The temperature should be maintained at a temperature where the patient is comfortable, and usually there are no ligature points where the patient can actually, frustrated people, then they are being secluded, no, they can actually harm themselves much more easily. They are impulsive, they are angry, they are irritable, so they can actually take the anger out on themselves also. So in seclusion, one of the highest risk is that they actually try to commit suicide. So you need to actually monitor a patient in seclusion very closely than anybody else. And these sheets are also of such quality that they won't be able to strangulate themselves. So that is geographical restraint, a seclusion room. If this is not possible, you should take the patient to a quiet area in the ward where there is not many visitors going in and out, and make sure that other people don't get into the fight. Physical restraint, of course, in older days, this is what is called a straight jacket. So they actually, put the hands, and the hands are actually then again tied in a certain way, tight. I don't know if you guys watched Mission Impossible. In Mission Impossible 3, the one where Tom Cruise tries to, rescue a criminal so that he can get something out of that person. I don't know if you watch that. That man is in a straight jacket. So usually prisoners, very violent or risky prisoners, even now are put in straight jackets where they can't move. So their hands and everything are restricted. During the times, this is from a museum actually, during the times when there were no medications to manage people who were violent, they used straight jackets to physically restrain people. Okay, somebody's video is on. Ashan, your video is on. I don't know where you are. You seem to be walking somewhere. So Ashan is walking around and okay, right. This is called the crib, again used in 1800s and 1700s, where they used to restrict people's movements. These were very inhuman ways of treating people with mental illness, because they believed that they are at risk of harming other people and others in the community. But with the development of antipsychotic medications, things became better. So geographical restraint can be in psychiatric intensive care units. When you go to NIMH, you will see sometimes from the OPD, patients are directly admitted to the PICU, where they are kept, where they are kept for some time till they are calmed down and they are sedated, and then they are transferred to wards. You can use a quieter part of the ward, you can use seclusion, and if the patient remains risky throughout, then of course you can use something like a forensic unit where it's a gated and closed, and risk is appropriately managed. The benefits versus risks in geographical restraint, it's very it should be as limited as possible, because you are actually restraining a person's ability to move, and it's very distressing for a person. You should not never put in a person in geographical restraint without first sedating, because they would be very distressed about their independence being restricted. And once the person becomes calm, you should always take out the person. Put them in seclusion, and once they are sedated, you open the door and the patient can himself walk out once they get up. And of course, when you sedate a patient, you need to monitor the patient, and the risk of suicide is always there when you put in a patient in seclusion without adequate sedation. So therefore, you need to monitor the patient. Terminate when it is not necessary. This basically means you open the door and let the patient come out when the patient is calm and quiet. Then, of course, if behavioral management does not work, if geographical restraint only does not work, you might, or else when you are using seclusion, or if you have had to use physical restraint, you need to actually use pharmacotherapy. So the ideal drug in that case should be something which is rapid acting, isn't it? Something which works very quickly. Otherwise, you can't be holding on to the patient and pulling him down for hours, no. And it should be easy to administer. So it should be either something which is orally dispersible, or something which is inhaled, or something which can be administered via intramuscular or intravenous preparation. It should have minimal side effects, and it should have minimal drug interactions, because these people would be on a lot of other medications at the same time. The two types of medications which are available to us are antipsychotics and benzodiazepines. What to use? Should we use an antipsychotic? Should we use a benzodiazepine? Will depend on the diagnosis, the level of aggression, and the route that you can give. If a person is psychotic, and you know that the patient is very ill, the risk of aggression is high, the patient has used antipsychotics before, then you might prefer to use an antipsychotic. If the person is antipsychotic naive, has never used antipsychotic before, you don't know how the reaction might be, or else the patient is not psychotic but maybe a little bit depressed, or patient is it's a behavioral intervention that the patient is needing, but it has not worked, then you might actually offer a benzodiazepine. If the patient refuses oral medication, then you might have to consider intramuscular medication. Always remember, you offer oral first. If the patient takes oral, you don't need to go for intramuscular, because intramuscular is always associated with high mortality. Oral first medications, you need to offer them. If the patient takes oral, you don't need to actually sedate the patient too much by giving intramuscular medication. What are the oral antipsychotics which we use? The preferred medication is the one which is given last here. I'm sorry, it should have come first. Orally dispersible olanzapine. So olanzapine, there is a preparation which dissolves orally and is absorbed via the oral mucosa. So you give that, and quickly the patient, it gets absorbed and the patient becomes sedated within around 15 to 20 minutes, right? If you don't have orally dispersible olanzapine, then if you have these medications, olanzapine, risperidone, quetiapine, or haloperidol, then they would work fast. If you don't have any of these, give any antipsychotic that you have. So maybe a little bit of chlorpromazine. Chlorpromazine is associated with a lot of drug interactions and hypotension, but chlorpromazine is a good oral antipsychotic for to be used as an oral medication for sedating a patient. Remember, intramuscular chlorpromazine is now contraindicated. It is banned because it causes so much mortality. So sudden cardiac deaths are very common with intramuscular chlorpromazine due to very severe hypotension. Benzodiazepines, we have few in Sri Lanka. So you have oral diazepam or clonazepam, lorazepam, midazolam. So lorazepam, I think, would be the best because it works quite fast. If you don't have that, then of course clonazepam, diazepam, or midazolam can be offered. If a patient is refusing oral medication, then you can actually give intramuscular medications. So you can give something like haloperidol, intramuscular haloperidol, 5 to 10 milligrams, even 2.5 milligrams. You can decide on whether the build of the patient and if the patient is antipsychotic naive or not. You can combine it promethazine 50 milligrams. When you go to NIMH, you will see that the intramuscular haloperidol being combined with midazolam. This is not something that we do in NHSL, but of course it's used in other places. But the risk is that, the combination of haloperidol and midazolam will have a higher risk of hypotension. That's why we are not using midazolam so much. Intramuscular olanzapine was available some time ago, but it's no longer available in Sri Lanka at the moment. For a few years, I have not seen it. So it was never available in the government sector. It was only available in the private sector. If you give only intramuscular midazolam, the risk is that the patient would be up and about in 2 hours' time. So you need to sedate the patient again when the patient becomes aggressive again. And that's going to be a little bit difficult. So if a patient is psychotic, I suggest that you choose an antipsychotic rather than just a benzodiazepine. You know the side effects of antipsychotics. So you oversedate a patient. So you give a higher dose than necessary. The patient might develop aspiration. How can this happen? How can you actually sedate a patient more than necessary? This often occurs because for the patient to get sedated. So for the first 20 minutes, you need to wait and see if the medication is working or not. So only after 20 to 30 minutes, you will repeat the oral dose or the intramuscular dose. Definitely in the IM dose, you need to wait for 20 minutes or more. If it is oral, then it will take even 30-40 minutes to start working because it has to be absorbed from the gastric mucosa. And that time, sometimes it's very difficult to wait. and you might have had to go for IM, tranquilization at the same time. So that might mean the patient, by the time the oral medications are absorbed, the patient has received 1 or 2 IM doses also. Patient is oversedated in the end at around 4 hours after the episode. Dehydration, because they don't often get up and take liquids. So the general rule is, when you sedate a patient, he should be sedated to a level where they get up, take a drink, and they take some food, and they go to the bathroom and then come back and sleep. That's the level of sedation that we say is needed. But then, of course, it's very difficult to titrate, and usually the patient actually ends up with oversedation or poor sedation, where they might need another doses. Hypotension is a killer. So they will develop sudden cardiac arrest and arrhythmias, and you need to actually monitor for that. NMS, maybe the next day after giving these medications. Dystonic reactions are very common. Respiratory depression with benzodiazepines. So how do you avoid complications? Take off the restraints once a patient is sleeping. So take them off. If you physically restrain, keep on physically restraining the patient, the risk is for NMS is very high. Keep left lateral low in the prone position to avoid aspiration. Monitor the pulse, blood pressure, respiratory rate, and temperature till the patient is up. That's the rule. So every 15 minutes till the patient is up. Monitor oxygen saturation, hydrate the patient well, and you do an ECG. If a patient has received at least even 1 dose of rapid tranquilization, you monitor the ECG, do a CPK level, do a serum electrolytes. So I have 3 messages for you from this lecture. Number 1, if a patient is aggressive, always exclude organic causes. Always offer oral medications first, and if you give medications for any reasons to manage aggression, always monitor the patient, because otherwise the risk of side effects are very high. Okay, now I have a few MCQs for you guys. I would like at least 10 people to send me the answers on chat. If you wouldn't like to send the answers for everybody to see, please, you can send me as a direct message. Please go through. I will give you 2 minutes to go through this. Please send me. Once you send me around 10 answers, I will discuss. Till then, I will wait. So they are just true-false answers. They are not SBRs. Following approaches help to manage an acutely disturbed patient. De-escalation, giving the patient as much choice as possible. Distraction, temporary separation from stressful family relationships. Physical restraint. Please send me the answers. So these are true false answers. So you have to put true false, true like that. I've received 3 up to now. Okay. 1, 2, 3, 4, 5, 6. Four more, please. 7, 8, 9, 10. Okay. So it's all true, actually. I'm happy. I'm very glad that you attempted this. De-escalation is trying to, de-escalate, calm down a patient. So it can be through calm communication, trying to negotiate a plan. So that is correct. Giving the patient as much choice as possible. That's correct. because you are actually as possible. So you're not saying that, you are giving the patient freedom to do whatever they want. If you give as much choice as possible, the patient would not actually feel restricted, or that their rights are being violated. So for example, if the patient says, I don't want an oral medication, I will go and I would sit down and I would not shout, that's okay. So then, okay, right, we will not give you medicine. You sit down and you try to calm down yourself. That's useful. Distraction is useful in a patient who might be delirious. For example, a patient sometimes even with dementia, when they are suspicious, when they have persecutory delusions, they actually become they have escalating irritability, and because of their poor memory, distraction is a useful technique, because you can distract the person to something else and the patient forgets what they were worried with. Temporary separation from stressful family relationships, yes. So sometimes people are aggressive when there is a lot of hostility, criticisms from family, and their mood is actually affected by these relationships. So if temporary separation helps. Sometimes how, even in wards, you have seen, patients and parents, especially mothers, they are arguing back and forth, and, you separate the mother and the patient, then the situation becomes much better. Physical restraint, of course, not always, but then, of course, there are instances where physical restraint has to be, done, and physical restraint has to be used. Okay. Second one, please send me the answers. Again, 10 people. Intramuscular midazolam causes following side effects. Again, true, true, false, like that. I've got 3 up to now. Please don't be hesitant. Just try them and send me the answers. Five. Read them and try them and send me. I'm not actually even looking at your answers like that. I just want you to attempt them. 6, 7, 8. Nine. One more. Looks like you guys have got stuck there. Anyway, intramuscular midazolam. Midazolam is a benzodiazepine, isn't it? It causes respiratory depression. Yes. Acute dystonic reactions? No, because acute dystonias are associated with dopamine blockade. So midazolam does not block dopamine. That's antipsychotic. So if you give haloperidol or olanzapine, yes, an acute dystonia can occur. Okay. Hypotension? Yes. So remember, that's why we are not usually combining midazolam with haloperidol, because both medications cause hypotension. Cardiac arrhythmias? Usually no. That's false because midazolam usually doesn't cause arrhythmias. It's more antipsychotics which cause arrhythmias. Similarly, neuroleptic malignant syndrome is not caused by midazolam, it's caused by antipsychotics. Okay. The third MCQ, please try this out and send me again, please quickly, around 10 people. Following are risk factors associated with violence in people with mental disorders. So, what you know about risk factors that we talked about for increased risk of violence. One, two, three, 4, 5, 6, 7, 8, 9, 10. Right. Substance misuse, yes. You remember that was one of the most prominent factors which increased risk of violence. Young age, yes. Male gender, yes. Past history of violence, we discussed, it's the most important factor. Remember, like in suicide. So in deliberate self-harm and suicide also, past history of an attempt is the most important predictive factor. Like that, in violence also, it is one of the most predictive important factors. Active psychotic symptoms, yes. Okay. The last slide, differences between NMS and Anidu, may I know when your next lecture is? Is it at 2:30 or 2:15?
2:30 minutes.
I'll take just 5 minutes. No, I'm sorry. So NMS is neuroleptic malignant syndrome is caused by antipsychotics, whereas serotonin syndrome is caused by serotonergic drugs. Both have a very rapid onset, but serotonin syndrome has more rapid onset than NMS. So it actually occurs within a few hours. So NMS occurs in an antipsychotic naive patient usually, a patient who, the usual history is that the antipsychotics have been started for the first time and they have been, either increased very quickly or another dopamine blocking agent had been added on to that. They are usually of extremes of age, so either elderly or younger people, very young, small children, and they might actually have medical comorbidities. So people with diabetes or any other neurological comorbidities are more likely to develop NMS if you prescribe antipsychotics. Serotonin syndrome, usually again there is recent commencement of a serotonergic drug. They are usually elderly and usually either there is a very rapid increase of the medication or there is combination of two serotonergic drugs like venlafaxine and maybe SSRI, which we usually do not actually combine. The prominent features of NMS, there is hyperpyrexia, so that's very prominent in NMS. The temperatures go above 103, 104. There is generalized muscular rigidity. Remember, in serotonin syndrome also there can be rigidity, but the differentiating factor is myoclonus, nystagmus, and tremor in serotonin syndrome. So if myoclonus occurs, you know it is serotonin syndrome and it is not NMS. In NMS, also autonomic disturbances occur, such as, the BP will fluctuate, there will be tachycardias, bradycardias, patient is sweating, there is lacrimation, salivation, and urinary incontinence. So both of them can have impaired consciousness. Again, in serotonin syndrome, you can see hyperpyrexia, but it's not as prominent as in NMS, and you can see autonomic symptoms can also occur. If you do investigations in NMS, you can see a WBC count, which is usually around 10-15,000, and CPK is usually more than 1,000. Differential diagnosis for both are very much similar. So for NMS, it is serotonin syndrome. For serotonin syndrome, it is NMS. You can have cerebral infections like encephalitis or meningitis. And then, of course, other psychiatric conditions like catatonia or heat stroke. Think about other sympathomimetic drugs and anticholinergic toxicity for serotonin syndrome. So they are bed bound for a long time. They have to be given ICU care. So all these complications of being bedridden will come, such as thromboembolism, pneumonias, and of course, with breakdown of muscle in NMS, they might go into renal failure and they might need dialysis. Cardiac arrhythmias and death are they have a very high mortality rate. Again, seizures and cardiac arrhythmias, those things in serotonin syndrome. So treatment is number one, you stop the drug, you discontinue the drug, cool the patient, sedate with benzodiazepines because they are very agitated, they are very sick. For NMS, you give that dantrolene to control the temperature, bromocriptine as dopamine agonist, maintain hydration, nutrition, and avoid aspiration. Serotonin syndrome also, you can give hydration. You can try anti-serotonergic agents, but these are usually not prescribed very often. Okay. Any questions? That brings us to the end of the lecture. Any questions?
Madam, why people with delirium they get worsen towards the latter part of the day?
Sorry, they people with delirium, they get.
Why their symptoms get worsen towards the latter part of the day?
Yeah, so this is called the sundown phenomenon. They have reversed biological rhythms. In delirium, the delirium, the lowered level of consciousness, and with the confusion, they become more agitated towards the evening. So they actually, people with subacute delirium, the first thing you will notice is that they will sleep during daytime. And in the night, they are awake and, they are running around and, people find it very difficult to manage them. It's usually because in the night there is less, the lighting is less, you can't see things clearly, and the organic process itself actually becomes worse with the biological rhythms in the evening. So that's called the sundowning phenomenon. Okay. Anything else? Any other questions? Sundowning phenomenon කියලා කියන්නේ ඉර බැස්සහම තමයි agitation එක වැඩි. That's why. Right, okay then. Thank you very much. I will upload the lecture into the LMS soon.